Okay, here we are with chapter 21. This is a four-part series in this chapter. In this one, we're going to talk about abdominal and gastrointestinal emergencies. So it's important to understand that GI issues can turn serious really quickly if they're not treated properly. And they can affect a lot more than just the gut. In fact, they can spread and cause issues with the entire body. So when it comes to things like abdominal pain, nausea, and diarrhea, tons of things can be going on to be causing this. Every year, GI problems lead to over 21 million hospital visits and around 250,000 deaths. Most GI issues are not deadly, septicemia kind of being a big exception, but they still take a major toll on our healthcare system. The most common issue that we see out there, of course, is GERD, or gastroesophageal reflux disease. It is really, really common, and this actually affects 25 to 40% of all Americans. Overall, 60 to 70 million people in the US deal with some type of digestive issue all the time, and this is according to the National Institute of Health. Some people are more likely to have GI issues based on their lifestyle and habits. For instance, there's two really big culprits that create or boost the amount of stomach acid that the body produces. Smoking, which it makes kind of smoking the culprit, but it's really anything that kind of has to do with nicotine. Nicotine kind of increases that stomach acid as part of what nicotine does to the body. Of course, heavy alcohol use is going to increase stomach acid as well. Some other everyday activities that can mess with your gut also are things that you wouldn't expect, like poor sleep or stressful and irregular work hours. Guess what? A lot of medics have gut issues. Lack of exercise, unhealthy diet, and even high stress levels can mess with your gut as well. So you add that in with smoking or alcohol use and those kinds of things, and it can, you're really predestined to have some issues if you're not careful. Any one of these things by themselves can irritate the digestive tract and throw normal digestion out of whack. It can be multitude of factors and not just a disease process. So from bite to bathroom, the trip of the food that we intake into our body takes anywhere from 8 to 72 hours. A lot of it depends on what it is that you're eating. Of course, remember, it's a team effort. The stomach, intestines, liver, pancreas, and other organs all play a role in this process of us absorbing all the nutrients that we need out of the food that we intake. Of course, as I mentioned, how fast this moves depends on a lot of what we eat, how much water is available, how much water we drink, the activity level, and of course, again, how stressed your body is. These images here show the abdominal quadrants that we commonly divide them into and what each quadrant contains. Knowing what is in each one of these quadrants can be helpful in determining the cause of a particular set of signs and symptoms that we may be presented with. But keep in mind that the abdomen is also known for its ability to cause referred pain, such as inflamed gallbladder might cause pain in the right shoulder, or indigestion might mimic what the patient feels as chest pain. So they can be a little tricky symptoms in there as well. The digestive process actually kicks off as soon as you take your first bite. The molars grind and crush the food, making it easier and safer to swallow. This also helps prevent aspiration or food going down the wrong pipe. Meanwhile, the enzymes in the saliva start to break down the complex carbohydrates into simple sugars so your body can absorb them more easily later on in the process. The mouth does more than just chew. It's of course the first step in the body's fuel processing system. So it's more than just chewing the food. It's actually kind of tearing it apart, breaking it down, and then adding the saliva and introducing some enzymes that's going to begin that digestive process. Swallowed food is then moved through the esophagus, which is that hollow tube, that mostly stays collapsed until food passes through it. If it didn't, it'd be very uncomfortable because it'd be full of air. The rhythmic muscle contractions that moves food down towards the stomach is called peristalsis. It's not an entirely perfect system when it comes to our resuscitation efforts, though, because during bag valve or bag mask ventilation, air can enter the esophagus as well as the lungs, which can lead to gastric distension and create lots of problems that way. The patient vomits and all that during that process. So it's not an absolutely perfect system when we go to kind of mess with it or to try to capitalize off of some of the features of it in emergency situations. It doesn't always work out well. In the stomach releases hydrochloric acid to help break down the food that we have taken in, breaks it down even further. The stomach will contract and churn the food, mixing it with acid to create this thick liquid called a chyme. Some small molecules like water, alcohol, caffeine, and some medications can actually be absorbed right there in the stomach. Alcohol is a perfect example of that. It's readily absorbed in the stomach and essentially goes straight to the liver through the portal vein. Once it's ready, the chyme moves through the pylorial sphincter into the duodenum. This is where the pancreas, liver, and gallbladder step in to help with digestion. So this table kind of shows the location and functions of the GI system and the related organs. And of course, it talks about the GI system, but then it's got other parts of things that are located in the body too. So no, the aorta is not technically part of the GI system, though. Remember, everything's connected. So each one of these kind of breaks down what that particular part of the GI system does. We're going to talk about each one of them, or the bigger parts of most of them, as we go down through this. Realize that the pancreas is one of those that we'll talk about in two different places. We'll talk about it here, and we'll also talk about it in the endocrine system. So it is an endocrine-exocrine organ, meaning it secretes things into the bloodstream of the body, and it secretes things that are external to the body. It's oftentimes a difficult concept to understand that the food that is actually in our digestive tract is considered external to the body because it's actually being separated by the lining of the intestines, and it may contain harmful or dangerous substances to our body, so it's kept separate, and the body only absorbs what it needs. The way that it does that is it uses all these enzymes and everything to break things down into smaller portions and parts, so that it can be absorbed through the lining in a safe way. And just a continuation of the previous table that shows the different parts of the digestive system and what it does, in that. This is purely a review of anatomy and physiology. If you're needing to dig into this a little bit deeper, I recommend you crack open that A&P book and review that chapter if you're struggling with any of it. So, the main function of the GI system is to absorb the food that we eat, to create or add fuel to the cells of the body. Absorption is the GI system's main job. It gets those nutrients into the bloodstream to fuel the body. About 90% of this happens in the small intestine. The pancreas helps out by releasing some enzymes into the duodenum. These enzymes can break down fats, proteins, and carbohydrates. It also neutralizes the stomach acid so the small intestine can do its job. Don't want a whole lot of stomach acids in the small intestine. The liver actually produces bile, which is stored in the gallbladder and is used to break down fats. This bile is essential in breaking down these fats. It also helps some with carbohydrate metabolism. If your blood glucose drops, the liver turns glycogen into glucose to raise it, so it's another little bit of the process that can happen there. The liver also plays a role in the cardiovascular system by filtering substances from the blood like drugs and other harmful things. So its connection with the the cardiovascular system and its role that it plays in the cardiovascular system is essential. It's like a giant oil filter or air filter that kind of filters out some of the junk that's floating through our bodies. It'll also break down old red blood cells that are no longer needed, and it can store some vitamins and minerals for later use in helping keep the body in balance. The portal vein that feeds the liver or actually passes through the liver, it transports all that nutrient-rich blood that's coming from the GI tract. So the GI tract's absorbed all of these nutrients, and then it passes it through the liver. The purpose of this is so the liver can filter out some of those impurities, such as alcohol. Alcohol is a big impurity, and actually it comes in straight from the stomach in through that portal vein. So alcohol hits the system pretty fast. The liver does its best to filter it out, but if you drink enough of it, it's not going to filter it, and it's going to pass on into the bloodstream, where it's going to affect the brain and all the other parts of the body. Now, the blood flow through the liver can slow down for a few reasons, such as vascular contraction or liver damage. If the blood backs up, the veins around the stomach and esophagus can dilate. Remember, these are veins, and they're not muscular arteries. So even a little extra pressure can cause these vessels to begin to leak or even rupture. This bleeding can range from a minor bleed to a very severe bleed, such as something with a severe case of esophageal varices where blood vessel in the esophagus ruptures. This is all part of the return flow of that hepatic vein. So, the colon moves through the remaining waste products, to be eliminated from the body. So the colon's going to carry all of those things that the body doesn't use or it's not going to absorb. And it's going to reabsorb a lot of water. So it's not going to it's really not absorbing anything but water in that process. It also contains a lot of bacteria because it's trying to continue to break down some of those things that are in there. And sometimes that bacteria, the breaking down of process of some of the things that we eat, creates gas. The bacteria lets off gas when it breaks those down, which is how we wind up with gas in our stomach. If the colon isn't doing its job, the result will be soft stools or diarrhea because it's not reabsorbing the water from from the digestive tract. This can happen if there's something such as a virus or something like that that's causing things to move through the large intestine at a much faster pace than it normally would, the large intestine doesn't have a chance to reabsorb that. Let's see, yeah. So that the completed process of the chyme, whatever's left over that the body couldn't absorb, is what was left from the stomach. And there's quite a bit of it from most of the time. And there's also some things along the way that maybe the liver kicks out some junk that it doesn't need anymore, and that kind of adds to that, to what's being excreted from the body. Of course, then we got this little thing called the appendix. We know now that it actually holds some T and B lymphocytes and produces immunoglobulin A. And it's thought to store good bacteria that can help keep the gut healthy. For a long time, it was believed that the appendix had no use or it didn't do anything. Since then, they've learned a lot more about it. So if the balance of bacteria in the colon gets disturbed due to like antibiotics, infections, or diarrhea, the healthy bacteria in the appendix may help to restore balance by migrating it to the colon. And restoring the normal flora of the large intestine. So, when dealing with patients that have GI issues, we're going to kind of follow a very similar assessment regimen that we do with most patients. Remember, most GI emergencies are often caused by medical conditions rather than trauma. Typically, when we get a call it's going to be much more medically related than trauma related. So getting a thorough history of the present illness is really, really helpful in, getting a good idea of what's going on with them. So when talking to the patient, ask about any dietary habits, any bowel movements or discharge from the body, and the types of pain that they may be experiencing. Have them describe those, point to where the pain is, and those kinds of things, which is really helpful. Of course, we're going to take standard precautions like we do with every patient. Remember, cleaning the patient isn't just about hygiene. It can also help restore a sense of dignity to someone dealing with a difficult circumstance, of their illness. So sometimes it's important for us to help clean a patient up. It's not a pleasant experience for them or us, but sometimes it can be really beneficial to the patient once we get them cleaned up, and then we can move on with the process of treating them and helping them get back to good health. But the big part of it is it really helps to restore some of their own personal dignity, not riding to the hospital in a pool or a puddle of their own waste. So we should make some effort to help try to clean them up whenever possible. So start by getting our general impression of the patient. Where were they found? What's their body position? Any particular odors present? And I know we're talking about GI, most of us are thinking about a particular odor, but that may not be the case. For example, an upper GI bleed can cause a really foul smelling stool that is a very distinctive smell. And smells are typically the strongest within the first minute. So remember to think of that when you first come in the room. Your nose is going to get tired, the olfactory nerve is going to get tired, it's going to tire quickly, and you're no longer going to smell that unless you go out and get a fresh air and then you come back in. So realize that your first smell, that when you smell it in the room in that first minute, is going to be probably your best window. After a couple of minutes, the nose is going to adjust and you won't smell hardly anything. It won't be near as noticeable unless it is extremely pungent. And then the olfactory nerve gets really irritated with this and it's not going to let go of that smell. It's going to stick with you and it's probably going to have that smell stuck in your nose for a few days, maybe. Let's hope not. If they vomited, there's a higher risk of aspiration. Realize that. Always inspect the airway for foreign bodies and suction or remove any obstructions. Be aware of any unusual odors. So if there's something that just really doesn't smell right. Patients sometimes with an advanced bowel obstruction their breath may actually smell like stools. So keep that in mind as well, because everything may be all backed up so much that everything's starting to come out the other end. Difficulty breathing with abdominal issues typically points to a very serious complication that is going to require immediate attention. Monitor the patient's capnography to ensure that they're breathing well. Keep an eye on it and make sure the patient's breathing stays effective. Giving high concentration of oxygen as needed may not be needed for every patient, but your capnography is going to help you make that determination. Of course, protect the airway and help prevent any kind of aspiration. Give a listen to the lung sounds and of course notate any breathing patterns, but make sure you're listening for any abnormal sounds where that maybe there's any evidence of aspiration prior to your arrival. Look at the skin color, temperature, and moisture, and of course check the pulse rate. And of course you want to be sure to compare what you're feeling with what you're seeing on the monitor. So seeing if the two are actually matching up, your pulse rate with your heart rate are matching up. What you're feeling is what you're seeing. And then you're going to make a transport decision. So you're going to use the information that you've gathered through your primary survey to guide your decision-making process. If the patient shows signs of positive orthostatic issues, so they have positive orthostatic vital signs, think carefully about how you want to move them. And be extra cautious when transporting patients in severe pain, because syncope is a real possibility when you go to move them. So choose the right mode of transportation. For most GI issues, lights and sirens aren't usually necessary unless the situation is critical. So when you're doing your history taking, of course, we're going to use sample. It's, a tried and true algorithm that we're going to use. Many patients with GI disorders have a history or long-standing history of other medical issues. So realize that these issues can quickly worsen or intensify. That's why it's important to ask them if this issue has happened before. And keep a common frame of reference in mind when you're doing this. What one person calls diarrhea, another might call a soft stool. So bear that in mind. You may need to have them describe a little bit more in detail about what it is that they're talking about. So some key questions that we should ask are, what food have they ate in the last 24 hours? Not necessarily just the last meal. Remember, we're talking about a GI issue, and it can take up to 24 hours for things to pass through the system. So the last 24 hours is going to be helpful. And of course, how well have they tolerated eating lately? Have they had issues with eating no matter what they ate, or is it certain things? Is there a chance they're pregnant? Are they having any pain or difficulty when swallowing? Has there been a change in bowel patterns or stool type and color? Recent diarrhea, constipation, nausea, vomiting, or even weight loss. Maybe they've traveled somewhere out of state or out of the country. And it's quite possibly that they've had a recent change in medications that's unrelated to GI issues, but maybe that new medication is causing some GI issues itself. All right, so how we describe things to other healthcare providers is important. This table is really just a way to kind of help standardize the language that we use to communicate to other healthcare providers when we're handing over care. So it's important that we all are using kind of a similar frame of reference and not just, kind of making up our own words or using the words that our mom or our Nana called it when we were little because it's embarrassing or something like that. We need to make sure that we're using the professional medical terminology that we would that those in the medical field would commonly use. Things such as melena or coffee grounds vomit or vomitus and those kinds of things. Those are words that are very common and they mean a particular thing. But telling them, oh, they made a duty or something like that is just not going to convey the same amount of information that needs to be conveyed to the staff or to other healthcare providers. So during our secondary assessment, there should be no major changes in the head, neck, or chest directly tied to GI issues. So we shouldn't expect to see a lot of things going on with the head, neck, or chest. So we should be able to kind of move on to the digestive tract or the GI, the gut area, to see what's going on. So there are some impacts the GI diseases can have on the nervous, cardiovascular, and respiratory systems, but they typically come from pain, low blood volume infection, and those types of things. And a more detailed exam of the abdomen is necessary in order for us to identify any of those GI concerns. But don't forget to check the skin for irregularities. Things such as scars or past traumas and surgeries, even stretch marks could indicate past issues with rapid weight gain or rapid weight loss, kind of as what we see in this picture here. This shows that someone had rapid weight gain more than likely, and now maybe they've had a significant weight loss that they're going through now. All of these can be indications of what's going on, or at least should cause us to ask a few more questions. Have you lost a lot of weight recently? Do you know why? Are you dieting? Are you doing whatever? Have you had whatever? Or if you notice a scar, you should ask questions. An asymmetrical abdomen is noteworthy, and it could be caused by things such as tumors, a hernia, enlarged or distorted organs, or something as simple as pregnancy. And I know pregnancy is not necessarily simple, but in the big scheme of things, it's typically not fatal. It is noteworthy to make note of if they are pregnant. So check for the shape of the abdomen. Look for shapes like a flat abdomen, which none of us in EMS have, or very few of us have. Most of ours are rounded. Some of ours are protuberant or bulging. I'm not sure I've ever seen a scaphoid abdomen or a concave abdomen, but I would imagine that it is entirely possible. Maybe that's the six-pack abs or something that, are the elusive abs that we all wish we had. A scaphoid abdomen actually indicates a decreased abdominal volume, so it may indicate that there's something going on there, and it could be, related to an eating disorder or something along those lines. So listen to the abdomen, put your stethoscope over that thing, listen for gurgles and clicks. These should be heard about 5 to 30 times per minute, so we should hear some activity in there. The classic stomach growling indicates the presence of strong intestinal contractions, which could be completely normal, or it could be signs of diarrhea. It all depends on maybe what they ate and when they ate last. Sometimes the stomach's a little overactive at the moment. Increased bowel activity can be a sign of an early bowel obstruction. Decreased might indicate an ongoing or a bowel obstruction that's been around a little bit longer. So as those bowel sounds decrease, things are not moving. Absent bowel sounds, meaning there's no sound for 2 minutes, may indicate that the intestines are not contracting, which is a very serious concern. Realize that the entire gut, small, large intestines, and stomach are all very, very vascular. It is entirely possible for someone, like with their heart attack, they can have a myocardial infarction, we can have a stroke or a CVA. They can have a mesenteric infarction as well, that can, cause damage to the intestines, and may cause them to completely stop working altogether. So the abdomen should sound tympanic when we percuss it, like a hollow, empty sound, like thumping on a basketball. The upper left and right quadrants should sound a little duller because of the liver in the upper right and the spleen in the upper left. So those two should sound a little bit different. They'll sound a little bit duller because those organs are solid. The abdomen should feel soft and non-tender. So check for discomfort, rigidity, and masses. And of course, rigidity may suggest hemorrhage or infection, or tenderness that they're guarding. They may be tightening up their abdomen because it's painful when you push on it. A painful abdomen can indicate any number of things. Of course, trauma could obviously be that, or it could be a hemorrhage. Bleeding into the abdominal cavity can cause pain and discomfort. Infection as well. It could mean there's an obstruction, or there could be some other serious issues, kind of like the one I mentioned, like a mesenteric infarction. Of course, there's 4 types of pain that we commonly associate with abdominal issues. There's the visceral, parietal, somatic, and referred. And we'll look at these a little bit deeper on this slide here. This kind of gives a breakdown of what those are, and I'm not going to go really deep into them. But visceral is typically associated with hollow organs. And of course, referred, as I mentioned earlier, you're feeling the pain somewhere else other than where that particular organ is. Always find that one the most fascinating of all of them, because our brain is typically not used to interpreting pain from our digestive organs. So I believe that the brain has a difficult time narrowing down where that pain is coming from, and it gives a false reading. So it comes as a referred pain, even though it's not there. For instance, a gallbladder, it's pretty common for a gallbladder to hurt in the right shoulder. Not everybody's that way. Some of them are, point tenderness right over the gallbladder itself. But these are typically the types of pains that we're looking at: visceral, parietal, somatic, and referred pain that we see in abdominal issues and during our assessment. Rebound tenderness happens when the peritoneum is irritated. It can accompany abdominal pain, and it could actually indicate a true life-threatening problem that may require urgent attention because, as mentioned, bleeding into the abdominal cavity can cause this to happen. When palpating, note the presence of any masses, which could suggest maybe an engorged liver from things getting backed up, the blood vessels being backed up, bowel distension, aortic aneurysm maybe, could be a cyst, could be tumors, and those kinds of things could all be present, or any one of those can be present, so they're all noteworthy. Obtain a good orthostatic set of vital signs. Kind of mentioned this a little bit earlier. So obtain the patient's orthostatic vital signs to determine the extent of any bleeding that they may have. Of course, don't do this if your patient is not stable. Clearly that should not be done. But if you have a patient that's otherwise stable and they're laying down and their blood pressure is fine, but you set them up and they get dizzy or lightheaded, that's when we want to do that, orthostatic vital sign test. We don't necessarily have to completely stand them up, but if we notice a positive tilt test from laying down to setting up, that is definitely noteworthy. And of course, if you stand them up, then it is too. But a 20 millimeter drop in the systolic pressure, a 10 millimeter drop in diastolic pressure, which indicates a narrowing pulse pressure, or a 20 beat increase in a pulse rate may suggest a significant blood loss. So when we do that tilt test, we lay them down and we set them up. We lay them down, take a blood pressure, and we set them up. And if we see a 20 millimeter drop in systolic, a 10 millimeter drop in diastolic, or a 20 millimeter or a 20 beat increase in their pulse rate, there could be an indication of significant blood loss, or they could be significantly dehydrated as well. This test can be taken a step further and to have them stand up. You do it laying, setting, and standing. You could do all three. But typically when we're doing a tilt test in the field, or we're getting orthostatic vital signs, typically the lying supine to setting up is enough to give us what we need to know, because standing them is typically not a practical thing for us to do. Ultrasound testing may be available in the field setting in some places. However, there's limited evidence supporting its use in the pre-hospital setting, but realize that the research and everything is still growing on this. This is more commonly used, ultrasound's more commonly used in critical care transport and in aeromedical aircraft. The information gathered by the ultrasound can help get to some more definitive care a little bit more quickly. May be able to kind of get a little bit of a window of what's going on inside the abdomen in some of those severe cases. Might help make a transport decision with that if you have the equipment available and you've been trained on how to use it. However, realize that ultrasound training for ultrasound tech is quite extensive training. So it's not just a matter of sticking a probe on there with some goop and being able to see or knowing what you're looking at. You'd need to have training to know what to look for specifically within that ultrasound, which makes it less practical in the field, and it's expensive. With all patients, of course, you should continue to provide routine monitoring of the pulse rate, the EKG, the blood pressure, respiratory rate, and pulse ox. That's just part of that whole reassessment routine. Of course, the frequency of when you do this is going to be really dependent upon the severity of the patient that you're dealing with. The more serious they are, the more frequent you're going to do it. The less serious, the less frequent you're going to do that, and you're going to move on to some other things. Look for signs of shock if your patient has any kind of a GI bleed. Capnography can actually help assess the degree of the shock by looking at the amount of CO2 that's being exhaled. Determine the effects of your treatment on the patient as well. This capnography will help you do. And of course, be objective in your documentation and treat your patient with respect whenever you're documenting all of those things. All right. So let's start in looking at some more specific emergency medical care that we're going to provide. So if your patient's condition suddenly changes or you notice a drastic change in their condition, repeat the assessment and adjust your care. They may begin to experience severe pain, dehydration, hypotension, and extreme nausea. Remember, these patients, as with nearly every patient that we transport, these patients should not be allowed to eat or drink anything. Because especially with GI patients or any patient that may wind up going to emergency surgery, food or drink could delay their ability to go to surgery and could delay the possibility of that treatment. Your main goals are observational and providing standard precautions. Maintaining those ABCs and managing pain, nausea, and vomiting are things that we're capable of doing in the field, and those are the things that we should focus on. And then continually providing that reassessment and going back and making sure that we're hitting all the marks. Of course, the goal of pain medication in the field is to make the patient more comfortable rather than eliminating the pain completely. Yes, that would be ideal, but that's not the goal. The goal is to make the pain manageable. Pain medications that we can use in the field are things such as Demerol. Demerol is a very effective pain medication for GI issues, and it's really good for moderate to severe pain. Of course, morphine we're very familiar with that, but realize it can cause some hypotension and respiratory depression if we're not careful with it. So that's something to consider with that. Toradol, which is a non-opioid analgesic for moderate to severe pain. This one is, because it's primarily filtered out of the body through the kidneys, we have to be cautious with that in renal disease. Or those that are bleeding or pregnant, they can be problematic as well. A really good choice, and it's one that we carry more and more these days, but it gets a lot of bad press, is fentanyl. It's a potent opiate. It's fast acting, but it has a short half-life. It can cause hypotension and respiratory depression. Respiratory depression it can cause for sure, but the hypotension oftentimes is not quite as bad as what morphine can cause. So sometimes it's a better choice between the two if you're able to make that choice. And the fact that it has that relatively short half-life is really, really helpful. Many services are typically nowadays carrying one or the other. They're either carrying morphine or fentanyl. Not many are carrying both. And some have some other options. I've not seen Demerol carried on an ambulance for quite some time, but it used to be very commonly carried on the ambulance. So for dehydrated patients, the main goal is to refill the cellular space. The degree of hemodynamic stability will guide whether a hypotonic or isotonic solution is used. Patients in a stable condition should receive a hypotonic solution at about 125 mils an hour. This moves fluids from the vascular space to the interstitial space and then to the intracellular space, helping to refill and kind of replenish the cells. This rate actually allows for some slow rehydration and avoiding some of the major issues that we might see with the shift in fluid volume or pushing the electrolytes around that might cause some issues. However, for severe dehydration, we're going to use an isotonic fluid. And really what we're trying to accomplish here is we're trying to re-expand the vascular space first. While the cells themselves are dehydrated, a decrease in blood volume is the life-threatening issue that we're dealing with. Once the vascular space refilling takes place, then we can start to focus more on the cellular rehydration. Refilling that space is crucial for ensuring adequate perfusion to the vital organs, so that's going to be our priority. Of course, volume replacement is going to be critical for ensuring adequate circulation to those vital organs. Aggressive volume replacement can lead to dramatic hemodilution, though. So realize there's kind of a happy place that we want to get to when we're talking about fluid replacement. And we want to titrate those fluids to try to achieve a blood pressure of around 90 to 100 millimeters of mercury. The reason for this is between 90 and 100, we get pretty good brain perfusion. Actually, anything above 80, we should get decent brain perfusion. So 90 and 100 gets us good brain perfusion. And that way, and most of the vital organs continue to get perfused. But we want to try to avoid trying to normalize the blood pressure, like get to 120/80, because if the container is leaking, the more pressure we put the container under, the more it's going to leak. So we just want to have enough pressure in there to maintain, and that way we can kind of limit the losses. Blood pressure cannot be maintained. If the blood pressure can't be maintained to ensure an adequate perfusion, we may have to consider using some vasoactive medications. Dopamine, norepinephrine, epinephrine are typically used. Fluid resuscitation should be performed first to ensure there is enough fluid volume before administering these medications. And then, of course, once at the hospital, they may begin to administer blood to begin that stabilization process. However, realize that it's becoming a little more common nowadays for there to be blood administration in the field. Primarily, we're seeing that done in trauma patients, not so much in medical patients. New research is kind of moving towards blood replacement in the field on medical patients as well, but they're not quite there yet. Okay, so that is part 1 of 4 on the GI tract. We will be back with part 2 with a little more information.